We now come to a necessary topic to be discussed, and that is surgical audit. Every government, after 100 days, 6 months, or 1 year, puts out its performance audit. When right from the government down to a small industry, when they regularly, diligently, and dutifully they put out their performance results, why should not the greatest and the most noblest profession in this world, namely medicine, surgery, why should we not have an audit? Is it something new? No. Especially in the West, there is a regular audit process that goes on. And what is an audit? An audit aims to look at the performance of the hospital, the surgeon. We are discussing about surgery, therefore we will be surgeon. That means how many cases has the surgeon operated, how many has been successful, what is the mortality, what is the morbidity. Morbidity means how many patients have stayed for more than the requisite period of time in the hospital as a result of some small complication or the other. Plus other factors like what are the costs that have been incurred, how many days has the patient spent in the ICU, was there a prolonged stay, was there a shortened stay, was there a requirement of multiple blood transfusions, were there infections, were there no infections, did the patient have excessive post-surgical bleeding, post-operative bleeding, did the patient have the necessity for prolonged ventilation, did the patient require any reoperation or emergency reoperative relook surgery, as we call it. So these are the few parameters. I repeat that the internet, you will find a huge amount of wealth about surgical audit. There are many types of surgical audit. There are many institutions which have a framework of surgical audit. In summary, every institute, every hospital can format their own brand of surgical audit, can format their own protocol of surgical audit. The main questions that need to be asked are, and they are in front of your screen. And what happens, what is the course of action after a surgical audit is conducted? Now, why should an audit be conducted first of all? Surgery is like a game of cricket, or like an actor, or like a superstar, or like a cricketer. You are as good as your last movie. You are as good as your last game. That's all. Just because you have scored a century, or just because you have taken 4 or 5 wickets, single 5-wicket haul in a particular innings, it doesn't mean that for the rest of your life your performance will be absolutely par excellence. No. Similarly, just because a surgeon has been accredited, he or she, it doesn't mean that he is indefeatable. Every surgeon is a human being. There are ups and downs during his or her career. So as a surgeon, I mean, it is ridiculous if someone says that I am a surgeon, my success rate is 100%. Matter is over. 100% success only God the Almighty can give. Nobody else can give 100% success. Therefore, let us not try to speak about this 100% success in surgery. There is nothing like 100% success. Every surgeon meets with failure, difficulties, complications during his or her journey throughout the professional life. It is a surgical audit maps the journey of a patient right from the time of admission throughout the course of treatment up till the time of discharge. It gives us an insight into the journey of the patient and the journey and the experience of the surgeon who has treated the patient. As a passing mention, I would like to say that despite the fact that this is a capsule on surgical audit, it can be transpolated, it can be extrapolated. The same philosophy can be Extrapolated to the medical fraternity, medical specialties also, wherein we can have a medical audit on the same lines. Coming back. So, a surgical audit gives a surgeon an insight into his or her strengths, weaknesses, deficiency and lacunae. Where did we go right? Where did we go wrong? Where can we improvise? Where are the deficiencies? How do we combat these deficiencies? How do we overcome these deficiencies? Ultimately, what is the aim of a surgical audit? The aim of a surgical audit is betterment of the treatment protocol, surgical skills, and who will be the final beneficiary? It is the patient who will be the final beneficiary. Why? Because better the surgeon, better the care, better it is for the patient. Therefore, a surgical audit primarily benefits the surgeon and the team, and most importantly or secondarily benefits the patient. There is nothing like a strict format of a surgical protocol, surgical audit, sorry. Every surgeon, every hospital, every institute can have their own protocol. Having said that, what is one of the biggest uses of a surgical audit? See, one of the biggest uses of a surgical audit is that it sheds light on the quality of surgery that is being performed by a particular center. What do we mean by quality of surgery? You see, this topic is of paramount importance. It would not be an exaggeration to say that from the time we have started this multi-part presentation, multi-capsule, multi-segment presentation, if there is any one factor that is above all in the field of surgery that needs to be discussed, especially at the national level, it is one word: quality of surgery. What do we mean by quality of surgery? Patient gets admitted, patient is successfully discharged from the hospital. That means patient has received a quality treatment. Is this the definition? No. Patient comes out of the theatre alive. Is this the definition of quality surgery? No. Patient gets into the ICU and comes out of the ventilator successfully. Is this the definition of quality surgery? No. Patient comes out of the ICU and shifted to the ward and is discharged. Hence, it can be assumed, or this is the definition of quality surgery. To the entire viewers, surgical fraternity, and in general, this patient coming out of the hospital alive is not the definition of quality of surgery. To give a concrete example of quality of surgery, I draw the attention of the viewers to the screen. We all know about coronary artery bypass surgery, also known as bypass surgery. There is a heart. The figure is evident. There is a heart. On the surface of the heart, there are vessels, blood pipes which carry blood to the heart muscle. These pipes get blocked because of cholesterol, sugar, tobacco, nicotine, smoking, alcohol, animal products, high cholesterol, etc. Blood supply to the muscle gets cut off or is diminished. Patient experiences a wide variety of symptoms we all know: chest pain, exhaustion, angina, dyspnea, palpitation. Some unfortunate patients, they have what is known as an acute coronary syndrome or a heart attack. That means a portion of the muscle does not receive the blood supply for some time and gets permanently or temporarily injured. What is the course of action to be taken? A new route of blood supply has to be created. In order for the new route to be created, as is evident on your screen, the source of supply is from the aorta, that is the main blood vessel, pure blood vessel. The point of delivery is beyond the point of obstruction, as is being shown on your screen. The question that is most important in between these two is, what is the pipe that is going to be used? In order to create a new pipeline pathway, what is the pipe that is going to be used, and how does this word quality, where does this fit into? What is the relation between quality and the pipe that is going to be fitted, what is the relation between these two? Why is this example being given? In order to underscore the or emphasize the importance of quality. There are two majority, there are two types of pipes that nature has given to a human being. One, as is shown on your screens, it is the veins on the legs. Veins meaning in the parlance of a common man, in the language of a common man, these are known as nerves. What we see, where injection is routinely given, those are those greenish colored vessels, pipes, which the common man, the non-medical person calls as veins. They are impure blood vessels. They are impure blood pipes. A length of a pipe, a particular segment of a pipe is taken from the leg and is used as a pipe. Point number one. This is one variety. On your screens is the image of the chest. On the undersurface of the chest, as is being shown to you, nature has provided a pure blood vessel. Just now we discussed about an impure blood vessel, the greenish colored vessel. In contradistinction to that, nature has provided what is known as a left internal mammary artery and right internal mammary artery. Let us not worry about technical words. This is a pure blood vessel that is present on the undersurface of the chest. This is a very unique pipe. Why? Because of two reasons. One, nature has created it in such a way that it almost provides an uninterrupted blood supply when connected to the blocked vessel. That means 25 years, 30 years, 35 years, it provides an uninterrupted blood supply. Unique property. Two, never ever does cholesterol redeposit in that pipe. Again, cholesterol, barring the fact that if the patient continues to smoke, etc., that we are not discussing. Three, it has the unique property of producing nitric oxide by itself. And nitric oxide continuously dilates the pipe. Dilates means its diameter becomes bigger and bigger and bigger as every day progresses or as time progresses. Because of these three outstanding characters, the connection of left internal mammary artery to the blocked pipe is of paramount importance. It will ensure that with all the other factors intact, the patient will have a lifespan of greater than 35 years. Therefore, what about the veins from the leg, the impure blood pipes? What about them? They are soft, they are veins, they carry only impure blood vessel, they cannot withstand these high pressures, and they are liable for redeposition of cholesterol after 1 year, 5 years, 7 years, 10 years, 12 years, or maximum 15 years. After that, they get blocked. Now the viewers can very easily understand that what is quality coronary bypass surgery. If a surgeon has the capability and efficiency, ability to connect these two pure blood vessels to the blocked vessels, both the right side and the left side, then technically it can be ensured that the patient has received international quality surgery. So quality surgery has been defined. If another surgeon, for example, is not capable, doesn't have that much of capability or ability to perform this surgery wherein these delicate vessels are taken out from under the surface of the heart and connected, it is a delicate procedure. Instead, that surgeon, with due respect, very smartly, without informing the patient, quietly takes out a piece from the leg, a segment, quietly connects it and comes out. No complication. Veins are very easy to handle. They are very soft. They are very pliable. They can withstand any amount of, small injuries also inadvertently. Surgeon comes out, patient comes out. A patient receiving vein grafts, as we call them, that is these impure blood vessels, he too comes out, he or she too walks out of the hospital on the 4th day, 5th day. A patient who has received pure blood vessels, he or she also will walk out of the 4th or 5th day. No difference from outside. Outside there will be only one incision that will be seen. Same incision, same stitches, same healing, both of patients will go out. Can you say that both of them have received the same quality of surgery? This patient who has received impure blood vessel graft, his or her graft will get blocked after 1, 5, 7, 10 or 12 years as the case may be. And that person will once again experience chest pain, palpitation, tiredness, whereas the other patient will have an excellent quality of life, trouble-free life, symptom-free life, good exercise tolerance, can lead an absolutely normal life up till 30-35 years and beyond. This is the best example of quality surgery that I can give. Why has this example been given? When you do a surgical audit, it can be seen in the operation notes. It will be mentioned what are the pipes that have been put. If a particular surgeon, with due respect, please forgive me, I am not personalizing anything, has gone on putting the impure blood vessels because they are very easy to handle and the surgery can be finished off very easily. He or she is depriving a patient of a potential lifespan, complication-free lifespan of 30-35 years and beyond. He or she is imposing a smaller lifespan on the patient. Therefore, a surgical audit will reveal these things and it will help in betterment of, it will help to strive for a better technique and a better quality of surgery. Therefore, this is the greatest use of a surgical audit. And so, before we conclude, a small summary which is there on your screens. The 3 factors which we need to focus as a part of surgical audit. 1. Has the surgery been performed as per international standards and international yardstick? Is there occurrence of unprecedented or unacceptable mortality, morbidity or complication in the hospital? 3. Most important, how have the patients performed on a long-term follow-up? Now, these 3 questions, we will briefly address them. We will address question number 3 first, long-term follow-up. This is the most critical thing as far as a surgeon's efficiency and as far as surgeon's ability and as far as the performance is concerned. As a passing mention, I must say that the Western world, despite the fact that India has a wealth of surgeons, the Western world does not recognize our performance. It is a fact. Why? Because we in our nation, we go on speaking about I have done 100 surgeries, 1000 surgeries, 2000, 3000, 5000, 10,000. Look at the profile of any surgeon and say I have performed 25,000 surgeries. That is not what the West is interested in. The West is not interested in number game. The West is interested in what has happened to your surgeries. How has the patient performed on a long term? What is your long term follow-up? Have you just operated and thrown the patient out of the hospital? Once in a while, the patient comes to the OPD, say, hi, how are you? That's it. That is not what the West looks at, and that is the reason why the West is what the West is. The Western nations are the nations who have pioneered research in medical and surgical fields. The Westerners are the people who have been pioneers in reading, in writing the textbooks that we read and become surgeons, specialists or super specialists. The West is the one that has pioneered research. The West is the term that has brought innovation. The Western world is the world that has set the standards of surgery. How? How have they been able to do it? By not just operating and throwing the patient and saying, I have performed 20,000 surgeries, 30,000 surgeries, 10,000 surgeries. They have followed up patients diligently with the help of surgical audits. Patient has got operated, whether it's an ulcer operation or whether it's a thyroid operation, whether it's a heart operation, brain operation, kidney operation, no matter what. They have maintained records, files, phone numbers, addresses. They have recontacted the patient. How has the performed? How is the patient doing? Whether it is cancer, let us say a tumor has been dissected. Has the tumor come back after 5 years, 10 years, 15 years? Where do you think all these data, how do you think all these data is incorporated into a textbook by research, by papers, by journals? Who has written these journals? The surgeons. How have they been able to document their data? Surgical audit. That's all. If we as a nation, we want to stand on par with the West as far as research or quality surgery. It is not enough to say 10,000, 20,000 surgeries. No, they are not going to take it. They're going to congratulate, they're going to say, oh, 20,000 surgeries, oh, very great, that this. They're going to turn around and laugh at us and say, what is the use of performing 20,000 surgeries when you don't even know what has happened to even one patient? Where is your records? Where are your records? Where is the follow-up? You have phone numbers, you have addresses, you have performance. Have you called the patient after 15 years and performed a re-angiogram to know whether the pipes that you have attached, are they blocked? Are they patent? Are they still functioning? A person has undergone a tumor resection, a malignant tumor, a cancerous tumor. What has happened to the follow-up? Stories of saying that all my patients are doing well, all of them are coming back, 100% success. We as a nation, we need surgical audit. If there have been complications, infections, prolonged ICU stay, then the surgical team or the team as a whole needs to go over their strategy and come out with those solutions which are going to offset this. And lastly, question number 1 about the technique. Patient, I repeat, patient coming out of the hospital is not the yardstick of quality. Patient has to receive that surgery, that quality of surgery, wherein, as deemed by the international standards, he or she will be trouble-free after 5 years, 10 years, 15, 20 or 25 years. So, this being the case, what is the process that MERC visions? There is an apex body, which we shall come to shortly. Every surgeon, or whether as an individual or as a department, they tabulate their results. It may be 6 monthly results or it may be yearly annual results. They tabulate these results and they send it across to the apex body. I mean, a question will be asked, a surgeon, how are you sure that he or she will give an honest report of his or her art? I mean, this we are not discussing. This is not the podium for discussion. Medicine is a noble profession. It is deemed that we are honest people and we will be putting forth an honest report of our results. So this being the case, naturally, these results will be sent to the apex body and an apex body will sit and go through the results and give an accreditation. We mentioned about surgical accreditation of an individual or of a department. That is the first type of accreditation. The second type of accreditation that MERC wishes to propose is a post-surgical audit accreditation. On your screen is a placard which shows the summary of various accreditations what MERC envisions about. Advantages of this surgical accreditation, ratifying or endorsing a surgeon's technical ability. One. Second, an accredited surgeon will fare better in the employment sector. The employer would definitely prefer a surgeon who has been accredited by the accrediting board or the authority, in contradistinction to a person who has not taken the accreditation examination. I hasten to say that just because a person has not taken the accreditation examination, MERC doesn't mean to say that somebody is inferior or somebody is superior. I don't. This is not a podium for any controversies. But having said that, this is a general advantage. Advantage number 2. Advantage number 3. There is a legal tussle or a legal question or a legal inquiry or a legal battle. Then the one strength that the surgeon can rely upon, and the one, I must say, quite a significant buttress that would help the surgeon in such a scenario would be the accreditation, because the court or the law would definitely take cognizance of the fact and give credit and give weightage to the fact that this is not some kind of a untrained surgeon or ill-trained surgeon. He is a surgeon who has received, he or she is a surgeon who has received accreditation. Having said that, something untoward has happened in this particular case. Therefore, so this is the view that law is likely to take. I'm not a lawyer, but I'm just telling.